Hello everyone, this is Michael Ibrahim. I'm today representing the clinical trial of cost effectiveness of Apixaban, dabigatran, rivaroxaban, and warfarin for stroke prevention in atrial fibrillation patients. The background and purpose of this study was a cost-effective of stroke prevention in non-valvular AFib patients by using a new oral anticoagulant Apixaban 5 mg, dabigatran 150 mg, and rivaroxaban 20 mg, compared with warfarin. The stroke is a substantial financial burden on healthcare system, patient, family, and society. Ischemic stroke in non-valvular AFib patient average about 5% per year, which is 2 to 7 times the rate of choose people without that condition. So the methods of this study, we used a Markov decision analysis model using data from clinical trials to evaluate lifetime cost and collay of this kind of medication compared with warfarin. The modeled population was a hypothetical cohort of 7 years old patient with non-valvular AFib, increased risk for stroke, CHADS 2 more than or equal 1. Renal clearance was more than 50 or equal to 50 milliliter per minute, and no previous contraindication to anticoagulant. If we move to the limitations, so this trial limited to patient over 7 years old with non-valvular AFib, CHADS 2 score equal to or more than 1, renal creatinine clearance equal or more than 50 milliliter per minute, and no previous contraindication to anticoagulant. Further analysis needed for other population section like the people less than 70 or have kind of problem with kidneys and creatinine clearance, or CHADS 2 score less than 1, or any kind of population not covered by this trial. There are differences among trial design, outcome definitions, and patient population, which lead to different outcomes and challenges the trial. Third, real life practice may lead to different outcomes due to different dosing regimen, compliance, and monitoring, comorbidities, and inclusion-exclusion criteria for sure. The resources were used to collect values for cost, utility, and other adverse events, such as stroke, disability after a stroke, introduce bias into the analysis as the last limitation we have. If we are gonna move on to the results section, in base case, Apixaban 5 mg collay was the highest of the anticoagulants by 8.47, whereas warfarin has the lowest collays estimate of 7.97. So Apixaban 5 mg provided an additional 0.5 collays at a cost of $7,513, resulting in ACER of $50,026 per collay gained below willing to pay threshold. One-way sensitivity analysis conducted for cost, utilities, probabilities, age, and discount rate did not substantially influence the ACER values of the new oral anticoagulant drugs compared with warfarin from base case, nor did the values exceed 50,000 per collay. That's the threshold. So, in conclusion, the new oral anticoagulants are more cost effective compared with warfarin. Treatment for stroke prevention in patients with new valvular atrial fibrillation. Of the three new oral anticoagulant drugs, Apixaban 5 mg was the preferred anticoagulant because it was a cost effective treatment option at all willing to pay threshold, which is more than 40,000 per collet. However, further analysis needed to evaluate of the cost effectiveness of new oral anticoagulant drugs instead of CHA2 score risk and hemorrhagic risk score, renal impairment, and age less than 70. Like the sectors not covered by this trial need more studies to get if that's gonna be cost effective for taking using Apixaban over warfarin. Healthcare providers already encounter choices between new oral anticoagulant drugs and warfarin in clinical practice for this high-risk population. Thank you for attendance, and I wish you a good evening. Take care.